check mark, but also a lot of red X's, right? No system, at least to date, or at least when I was also coming up in this work, really was capturing, kind of met all of those benchmarks for what I was looking for in a tool and a measurement system to think about, oh, could we answer these questions? Because we didn't really know, right? We haven't known that much about how language, that language producing context actually relates to more of those underlying organic causes. So I realized fundamentally, I was looking for a unicorn, right? A system that did not actually exist. And so this was nearly a decade ago at the time that I was meeting with my mentor at the time, Stephen Wilson. This was at the University of Arizona. And we thought, okay, well, if no such system exists, then perhaps we should create our own. And at the time, we were really inspired just from watching a lot of videos and talking with other experts in the field by how assessment is done in neuromotor speech disorders. And I'm guessing most of you all here are familiar with that assessment approach, but they call it the auditory-perceptual approach, right? So I'm talking about things like the Mayo Classification System for Dysarthria or the Apraxia Speech Rating Scale. This is where a large number of discernible perceptual features are each rated on a graded scale, right? So we thought, could we systematically apply that to aphasia and to be thinking about naturalistic language or connected speech? So we developed auditory perceptual rating of connected speech and aphasia, or what we call APROCSA. We published this work in 2019 in the American Journal of Speech Language Pathology. As you can see on the right-hand side, it's actually showing you the tool itself. It's quite simple. It requires no technology. It takes about a max 15 minutes to do. What you do is you collect a language sample, you listen for those salient features that I just talked about, but we defined and operationalized them. And importantly, we were thinking about ones that just we commonly heard and ones that also bridge both in from that were both on the language side of things, but also on the speech side of things potentially, because concomitant motor speech disorders are so common often. They commonly co-occur with aphasia. So we define things like semantic paraphasia, short and simplified utterances, false starts, etc. And each of those are rated on a 5-point scale, 0 to 4, with higher scores indicating greater impairment, as you can see here on the screen. And so in that work, what we found was that this system, our APROCSA system, was reliable when used both by student clinicians and by folks who are more expert and experienced in aphasia. And we also found that it showed strong concordance with more established metrics. And so those were our transcription-based metrics that we often use in connected speech, but also that there were associations with more broad stroke metrics from aphasia battery, such as the Western Aphasia Battery. The last thing we found that's really critical, I think, and perhaps was of most interest at the time, was that the system was multidimensional. So we came in not really with any strong assumptions about how these different features might co-occur with one another in systematic ways. And so we conducted an exploratory factor analysis to just see if there were any systematic patterns in people's performance, and there were. So we extracted 4 factors, and this is the results. I'm going to walk you through them because they're important to understanding the later studies that I'm going to talk about. So what you see here is the features from APROCSA on the y-axis, and then the loadings from that factor analysis on the x-axis. And we named the factors based on just that co-occurrence of features that we saw. The strength of those loadings is essentially a correlation between that feature and that underlying factor or dimension. Blue indicates the darkness of the color indicates the strength of the association. You can also see the values. Blue indicates a positive association, red indicates a negative association. So to talk about each of them, the first one we have is called paraphasia. This is the misselection of words and sounds, and I think that's pretty evident from the features that comprise it, right? And so here, speech is empty. It's often filled with semantic and phonemic paraphasias. We often see paragrammatism, or that mixing up of grammatical words. We also see a decent amount of self-correction, so people will often have false starts or retracings, and the consequence of all of this together is that the meaning of the message is unclear. The second factor or dimension we call logopenia, and this is not to be mistaken with the logopenic variant of PPA, but perhaps the more traditional definition, which means paucity of output or paucity of speech. So here we found that output was highly anomic, where utterances were frequently abandoned or perseverated. There are pauses frequently, both within and between utterances, and speech overall is halting, effortful, and slow, and yet again, that meaning is unclear. Our third dimension we called agrammatism, which hopefully should be really quite straightforward to everyone here. But this was defined by omission of grammatical markers and simplification, right? So utterances were short and simple in their syntactic complexity. We also found it was associated with stereotypies and negatively associated with self-correction, actually. So folks were a little bit more purposeful or deliberate in how they were crafting their utterances. And then yet again, we're seeing this theme of that consequence that the overall meaning of the message was unclear, and that overall agrammatism was associated with just general aphasia severity in terms of language production. The last dimension we had was motor speech. So it's really actually capturing those concomitant deficits we can often see with aphasia. And so here speech is marked by pauses, again, mostly between utterances. Again, speech is halting, it's effortful, it's slow, and critically the target is unclear, meaning the phonemes or the entire word themselves are distorted to the point where you may not know what that phoneme or that word is. And of course would be strongly associated with one of those co-occurring motor speech disorders, apraxia of speech. So what we concluded overall was that these dimensions, and critically, the idea is that they're not people don't just fit in one camp or the other. It's all about relative strengths and weaknesses across all four of them, but that these dimensions tell us something about the nature of speech language processing. And so what do I mean by that? So if we take those features all listed here on the left, right, these are ones that we can actually readily hear and rate and assign a number to. And then we can think about those on one side of the continuum. And then on the other side of the continuum, we have these nebulous, unobservable speech language constructs that we're always talking about, that we're often always targeting. We're targeting in our assessments. We're trying to, may have movement on them in our treatments, right? But we can't actually directly observe them. And we might nitpick the actual definitions exactly of what they are, the terminology, but just for example, we have lexical semantic access, morphosyntactic construction, phonological encoding, and speech motor processing kind of hits the main ones that we typically talk about. So how do we kind of connect these two? Well, we can connect them via those dimensions, right? So paraphasia and logopenia can be understood as reflecting deficits in lexical semantic access and phonological encoding of kind of two different flavors, right? So in the case with paraphasia, it's more likely that some competitor words, right, whether they're function words, more grammatical words, or they're content words, are arising, right? And so we're getting all of that misselection. Or in the case of logopenia, those aren't even actually arising to the occasion for them to produce a word, right? So we're getting that passive outputs, and because we're just not quite getting there to be actually able to say a word or to say a phrase. In terms of the other two, they're a little bit more straightforward. So morphosyntactic instruction we can see as being reflected within agrammatism, and then speech motor processing we can see as being reflected in motor speech. And then those in turn are linked to these sets of readily measurable and observable features that are actually part of the APROCSA system. So after doing this study, we were really excited. We thought we got more than actually we bargained for. We had a tool that we felt like we could use. And so that's how we got to where we are now, is we wanted to answer important questions about naturalistic language production in aphasia. And this is a bulk of a really big part of my research program at present. We have many projects ongoing or completed currently, but I'm going to mostly focus on two studies that were part of my dissertation work and that were funded by an F-31 training grant from NIDCD. So the first question in this realm, and this really is about kind of that relating back to that organic cause, was how does naturalistic language production map onto brain damage? And this was work that we published earlier this year in the journal Brain. So I'm just going to walk you through what that work was. So how we did this was that we leveraged a large longitudinal research study. I was working, as Sigfus mentioned, at Vanderbilt. We have a large longitudinal stroke recovery study that's run by Stephen Wilson and Mike Doristal there. So what we do is in the first 5 days post-stroke, for anyone who experienced a left-sided stroke, we evaluate them at bedside. We do some speech language testing that includes obtaining a language sample, and then we also obtain their clinical imaging, so CT and MRI. If they indeed have aphasia, we follow up with them at 1 month, 3 months, and 12 months post-onset. We do that same speech language testing and collect yet another language sample. We also will do imaging if that's we're able to, but that's kind of outside the scope of what I'll be talking about here. But if you're curious, I've got some papers, just some examples of some of the work we've published that's part of that larger study. You can check that out. We were mostly for these studies, though, interested in that follow-up behavioral data. All right, so we used this longitudinal study. For this particular study, we were only interested in looking at folks with acute stroke, and the idea being that that might actually give us some more pure brain behavior associations because the brain itself had not yet had a chance to kind of heal and reorganize, and also it hasn't necessarily had much of a time to respond to behavioral interventions. So we looked at that acute time point, and we looked at folks within about a 3.5-year period. 118 of those individuals we had recruited met our inclusion criteria. And so what we then did is that we wanted to look at brain behavior association, so specifically the dimension scores with areas of brain damage. I've got a video going here in the bottom left of one of my colleagues, Anna Kasdan, actually defining what brain damage is. For those of you who might not do this kind of work, I thought it might be fun for you to be able to see and kind of get a sense of what goes on under the hood. We do manual tracing, so this is actually a scan, and she's going through in some software and actually literally tracing and drawing it out where the damage is, which is bright on the particular images you see there. So as that's playing, that's kind of to give you a sense of what the brain damage actually is and how we get numbers from that. Up above it is the actual dimension source. So we created a scoring system based on that factor analysis. So it would give us a graded 0 to 100 score on each of those 4 dimensions. So each person got 4 scores. Again, higher scores indicate greater impairment. You can just see the spread of those scores for those 118 individuals here. And so we took those and we related them in our 118 individuals in 2 different ways. We related them voxel-wise, or we just did a whole brain analysis where one particular voxel or pixel in that image, how did that brain damage relate to those 4 different behavioral scores? What you can see here is just a lesion overlay of those 118 individuals. The hotter color is indicating more people had damage in that area. And then we wanted to do a complementary analysis using regions of interest. And please ask me questions if you're more curious about how we defined our ROIs, but we had 4 of them, 3 of which are depicted here. We had prefrontal, frontoparietal, and temporal. And then we defined a 4th one that's not really picturable here, but it's essentially any other damage kind of outside of these core language areas within the left hemisphere. And we considered those essentially non-language regions. So we had those 4 ROIs. And why we wanted to do this because we wanted to do different types of analyses, and we wanted to ensure that we were getting converging evidence from both types of analyses. And so what we found was that 2 dimensions relied primarily on posterior brain regions. So what we're seeing here are the results from both of those analyses for the paraphasia and logopenia dimensions. On the left side, you're seeing the voxel-wise results. On the right side, you're seeing the ROI results. The left side is simply showing you the actual statistical findings projected onto a template brain. So either a 3D rendering of the surface of the left hemisphere or slices that are actually coming through in the axial plane that kind of cut through those core language areas. The ROI figures that you're seeing or panels that you see on the right-hand side of the screen, those are what we call, they're just essentially associations between the behavioral score and damage in that particular ROI when we factored out damage from those other ROIs. So just really that unique contribution. And so the boxes are indicating, if you see a box highlighted around one of those, that's indicating a significant association. And I apologize, the font is so super small, you probably can't read it, but I'll walk you through it and tell you what we found. So for both paraphasia and logopenia, we found that, like I said, that there was these mostly involving these posterior brain regions. And if we really tried to tease it actually further apart, we found that paraphasia was most uniquely associated with left posterior superior temporal regions. So like posterior superior temporal gyrus or temporal sulcus. That's reflected in the voxel-wise analysis and then also in the ROI analysis where the temporal ROI was the only significant predictor. And then in terms of logopenia, again, centrally mostly on those posterior brain regions, but more actually focused in parietal areas. So we did find that the frontoparietal ROI and temporal ROI were significantly associated with scores on the logopenia dimension. But when we kind of did some further analyses, we found really it was that particularly the angular gyrus that came out and supramarginal gyrus that were more significantly associated with the logopenia dimension when we considered all other factors. So that was our two kind of posterior dimensions and brain behavior associations. The other two were anterior. So for agrammatism, perhaps unsurprisingly, we had left frontal regions. I'll talk a little bit more about specifics in a second. And then motor speech, again, we also had those as well. Again, the setup for these slides is the same with the voxel-wise results on the left and the ROI results on the right. I want to communicate how overlapping these findings were when we even tried to further tease them apart. They were so close and congruent with one another. We can also see that reflected in the ROI results and that the frontoparietal ROI was a significantly associated with both of them. But importantly, more specifically, it was the left ventral precentral gyrus that was associated with both of them. Not so much as common of a finding that we see particularly in agrammatism, right? We often think of inferior frontal gyrus, maybe some other areas, but we did not find that in our study, and I'm happy to talk about why that might be at the end if anyone has questions. But with a lot of convergence here and all really centrally on those anterior regions in the left frontal lobe. So thinking about that in sum, we found that naturalistic language production overall relies on these distinct yet overlapping brain regions, and it really kind of marries two traditions of literature that we have in this field, right? And so I keep making this anterior-posterior divide, right? We often think of that in terms of our fluent, non-fluent dichotomy, right? Folks who are fluent tend to have involvement in posterior regions, non-fluent in those more anterior regions. That really kind of matches if we think about the co-occurrence of those features and what make up these different dimensions, that really matches that work that's been more syndrome-based, right, in our field, thinking about Broca's aphasia or Wernicke's aphasia, et cetera. It also, though, is congruent with more modern conceptions. We're relying more on thinking about things in terms of speech language processes, though, right? And so what we know from other studies that have done brain behavior associations, maybe some more large scale ones that have done big neuropsych batteries, is that lexical semantic access and phonological encoding, right, which make up the paraphasia and logopenia dimension, those are associated with posterior regions or very similar, right, temporal parietal areas that we found. And that morphosyntactic construction and speech motor processing, again, from those like bigger vowels, are associated with agrammatism and motor speech. But what I want to really emphasize that we were able to do here is we were able to do a comprehensive evaluation on folks in acute care in less than 15 minutes of evaluation time. So we're getting very similar congruent, right, findings and also converging evidence across, right, traditions in our field with a very brief and clinically applicable tool that also can be very easy to communicate to patients. Everything about this study was designed to be able to give a clinician the tools that they needed to actually sit down and chat with a patient. So you could actually get a language sample, score them on APROCSA, take a look at their clinical imaging, and actually be like, okay, I'm noticing that you're missing a lot of grammatical markers and there's this haltingness and some distortions that are like apraxia. That all makes sense with the fact that you have damage in the left frontal lobe, right? You could actually bring all that together really quickly. So we were really excited that we were able to kind of, that we had the findings that we had and that this all came together so nicely. So that was the first study. The next study, which we are still just about to wrap up actually, it was about recovery. So how does naturalistic language recover, and how does that relate to areas of brain damage? Um, so for this study, we again leveraged that large longitudinal study, but this time we were looking at folks across the recovery continuum. And so we were able to broaden the number of people we could include, and we also broadened the number of folks we had in terms of our recruitment period. So the black isn't showing you, we had all of the folks from the prior study, and then the orange is the folks that we added for this study, adding up to 225 in total. And the way that we approached this study was that we used growth curve modeling. It's just a type of multi-level model that allows us to actually quantify recovery and add in predictors to see how, or just change over time, how that is associated with outcomes of recovery. And I'll talk a little bit more about that in just a second. So we took scores across those 4 time points. What you're seeing here is just the raw data. Again, the dimension scores on the y-axis, over time on the x-axis. The color lines are indicating the mean. The grade lines are actually showing each individual person. You can, that heterogeneity, that is variability that we know so well in aphasia and in aphasia recovery. So we took those scores, and then first we were interested just how to model recovery. How much did people recover across these different dimensions? So I just use coffee cups and sizes as an example. My sister used to work at Starbucks, so we had a good laugh about this. So we wanted to model behavioral recovery, and then we wanted to think about those areas of brain damage. And because of the kind of modeling we were doing, we couldn't make use of that voxel-wise system, but we had done those ROIs. We had some, hypotheses, and so we were going to do those again. Let's use those same 4 ROIs. You're seeing the spread just on the left-hand panel there below. And so we were interested in outcomes. So we were just instead, now this time, instead of looking at acute, we were looking across all of the 4 time points. How were those associated with damage in those ROIs? And then critically, we really wanted to understand recovery. And so what was the interaction between the rate of change behaviorally and those areas of damage? How much did those actually matter in terms of how much someone recovered on one dimension versus another? And what we found here is that behavioral recovery is multidimensional. So this is just the model predicted recovery for these 4 dimensions. So the line is just showing you actually the coefficient or that rate change. And then the shaded is the 95% confidence interval. Again, scores on the y-axis, over time on the x-axis. What you can kind of appreciate is that we're seeing that very predictable pattern, right? We're seeing a decelerating trajectory, right? So people, their scores are decreasing, which is what we'd expect, right? Because higher scores indicate greater impairment, but the rate at which they're decreasing slows as they get further out into their recovery. Again, something that we know really well from the recovery literature at large. But one thing that we noticed is that some folks are kind of starting off at higher or lower scores. Please ask me about thoughts on this at the end if you have any, and I can share mine. But folks are starting out at different places, but also the rate at which they recover is pretty different. And in particular, logopenia, folks are recovering at a greater rate than the rest of the dimensions. And actually, if we were to get a bit more into the weeds, for example, agrammatism recovers at actually the least. So there's actually some gradation across all 4 dimensions at the rate at which folks recover over that first year after stroke. So that was the behavioral findings. Then we were interested in those brain regions and how those were associated with outcomes. And what we found was that the brain regions important in acute stroke are also important to long-term outcomes. So we essentially got a replication of the findings that we had from the acute study into considering all 4 time points at the same time, with one exception that I'll talk about in just a moment. So what we're seeing here, this is all of the ROI results, but I'm actually projecting the ROIs color-coded here just so to give you a kind of an analogous visual image to the prior study. And so for paraphasia, we found, and again, we have a similar type of correlation, kind of partial correlation plot that's showing us the association between the scores and the damage in that ROI. But what we found was that paraphasia was uniquely associated with the temporal ROI, and logopenia was uniquely associated with the frontoparietal ROI, right? Again, what we would expect from what we saw in the acute, the study focused on acute stroke and acute aphasia. And then what we found in terms of the agrammatism and motor speech, we found, I'll talk about motor speech actually first because agrammatism is the outlier. Motor speech was uniquely associated with that frontoparietal ROI, and agrammatism was as well. However, it was also associated with that other ROI, that kind of non-language ROI. And that's going to become important when I start to talk a little bit more about recovery here in just a minute, because it seems that maybe as we get farther out, that brain regions we might think of as non-canonically for language might actually kind of be playing more of a role. And so we only got this statistically significant finding for agrammatism, but I'll point out with my cursor, if you take a look right here, that's the agrammatism one. If we look at motor speech, and then we look at paraphasia and logopenia, we actually, if we look at just the coefficient line that's plotted, it looks like it could potentially be significant. It's not flat, but we'll see our confidence intervals are quite wide. And you might find this remarkable because oftentimes in aphasia, we don't have large cohorts, but 225, we were a little bit underpowered. And so that's part of the reason why we're currently working towards building up this sample, is that we think that we might actually get systematic associations for all of these with that other ROI, again, indicating that it's maybe playing a more important role than we had realized. The last kind of set of analyses that we looked at as part of this study were, again, related to that, specifically that recovery or that actual like mean rate change and how brain damage affected that. There were a lot of interesting findings that we had, but I'm going to hone in on 3 core ones for now. What we are looking at here are the findings for these. These are interaction plots, and for those of you who are not as familiar with them, we're again looking at scores on the y-axis as a function of time on the x-axis. However, here we've actually broken out what that recovery or that mean rate change behaviorally is. It's conditioned on the amount of damage in a particular ROI. And so, for example, here we're going to talk about the frontoparietal ROI, but we'll talk about some others as well. The darkest color is showing you the mean rate change for folks who have no damage in this area or 0. The middle color for these 4 panels is actually the mean amount of damage across this, the entire cohort. And then the lightest color is 2 standard deviations above that mean. And so when we're looking at interaction plots, we're wanting to know, are those lines parallel, right? Is there kind of no interaction between our conditional factor, which here is the ROIs, versus that actual predictor or not. And so lines parallel, there's no significant association or interaction. Lines converging or diverging, there's a significant interaction. And again, I'm indicating those with those boxes highlighted. And so what we found, one of the first core findings, was that frontoparietal damage matters less over time, right? And so we can see this kind of most markedly with the significant finding of agrammatism, right? It starts more fanned out in the beginning, that the amount of damage really kind of mattered in terms of how agrammatic they presented as. But as they got to that first year, it really did not make that much of a difference. And we see a similar yet less striking pattern in motor speech. And if we were to really squint, or if I would actually to try to change the scaling on the 2 figures here, we would see some potential trends in paraphasia and logopenia. Again, getting back to that fact that we're just a little underpowered, I think, despite the sample size. I think actually would be seeing those trends as well. They'd be a little bit more visible. This is very much in line if we think about work that's been done more in syndrome-based work, where we talk about, for example, Broca's aphasia, and that folks with left frontal damage often tend to have pretty good recoveries, right? There seems to be this, suggests us something about the left frontal lobe that has some, and maybe even parts of the parietal lobe that has some redundancy, right? That it can, other areas of the brain, now this study does not tell us what those are, but other areas of the brain seem to be able to take on that role that it originally had. So that was kind of our first key finding. Our second finding likely is also not surprising and something that we've seen in the literature, but again, hasn't been measured this systematically, at least to our knowledge, using naturalistic language and then using a clinically applicable tool. And this is that left temporal damage is immovable over time. And I don't think we're necessarily underpowered here because we have wildly large p-values for these that are very non-significant. So we have parallel lines here across the board, right? We're not seeing any interactions. And this really, speaks to the prior literature that's out there, both historic and more recent, that when you have damage to the left temporal lobe, it seems that those areas are so specialized that there's not really anywhere else in the brain that can take on that role. So your recovery is going to be really kind of dictated and fixed by what the amount of damage you have in that particular area. All right. Our last finding that I wanted to go over is about those non-language areas, right? That other ROI, which was beyond the ones that we were talking about. We found an opposing effect to the the frontoparietal ROI, and that we found that at least statistically significant finding, and a pretty robust and large one, was that damage to non-language areas for agrammatism matters more over time. So if you look at this figure in the very beginning, there's essentially these lines are converging, right? You could have a lot of damage or a little damage. It really did not have much of an effect on how agrammatic you might have sounded. But boy, as you get to a year out, that really starts to matter. And we could debate the construct of agrammatism and what exactly that might suggest about the nature of agrammatic speech. But I will point out that there is a trend towards this, again, not significant, but a trend towards it with all of the other dimensions, right? And so again, we look at logopenia, close together, starts to fan out towards not so much. See the same thing even with paraphasia and a teeny bit for motor speech, right? So again, I talk about this, we're wanting to build up this sample because I think this is really intriguing. If we think about what I'm doing right now, there is a cognitive load, right, to language produced in context. Maybe that isn't there when we're naming pictures or repeating words, right? And we might be actually capturing that a bit in terms of recovery and how people are compensating and making use of language and context over time. I know there is some prior work that suggests this could be important, right? And so this is just yet another study that might potentially be suggesting the importance of non-language areas in the left hemisphere in terms of recovery. Again, more to be done with the larger sample when we have a little bit more data, but I think this is really intriguing and promising. The other findings are a bit more kind of closely aligned with some more traditional research. This is a little bit more, at least from our perspective, novel. All right. So those were those two core studies. Like I said, I really kind of wanted to focus on that were more on the organic side of things. Again, please ask me about some others that we're working on. But fundamentally, I also, as I have been doing this work, I think about, there's always more work to do, and where is my heart and where do I really want to see this work go? And so much of what I'm going to talk about now to wrap up was inspired by my work as part of the implementation science working group with CATS, or the collaboration of aphasia trialists, right? I talked at the beginning about how important naturalistic language is, about how hard it is to measure, how we wanted to create tools that were applicable that clinicians could use. We got to actually get those in the hands of clinicians. Otherwise, what's the point, right? So this next body of work is all about the implementation of APROCSA. So first of all, so I'm going to talk about, again, we've done a couple of different studies in this area, but I'm going to talk about two of them for now. Both of these are currently in press and actually should be out in the world literally any day now. So stay tuned. This first project was actually our most recent one. It was led by an undergraduate named Cheryl Chong at University of Queensland. She did this as kind of her culminating thesis. And she was interested in, could we actually further simplify APROCSA for underserved and fast-paced clinical settings? So to give an example, right, APROCSA does require, upwards of 15 minutes. If you're someone who works in a skilled nursing facility or acute care, that actually is a really long time when you've got a stroke eval and you've got other things that you've got to consider, right? the other thing that, we had discussed was that, for example, and this was a new information for me, in Aboriginal Australia, they access to speech pathologists isn't necessarily easy. Often health technicians might be filling that role. So having a tool that was even further simplified that maybe other professionals with some training or maybe no training could use. So the way that she set this up was that she recruited some bachelor's fourth year students who were in speech pathology. The kind of culminating degree in Australia is a bachelor's degree. And she just gave them some pretty simple instructions, and she asked them to rate the dimensions directly. So instead of doing all 27 features and then deriving those 4 summary scores, it's just to go ahead and rate what you hear at the dimension level. And she used, we can see an example kind of her setup here in this top left-hand corner, right? And they just took a dot and they dragged it from anywhere from absent to profound. And then as part of this, they did this with, I'm going to talk about a data set that we have where we have expert consensus scores for these dimensions. And they got feedback in the form of getting to see where those expert consensus scores were relative to their own rankings, and then ratings, and then they could move on to the next sample and to the next samples. That's kind of how the whole procedure went. What we found in terms of their students' reliability in just rating those dimensions directly was it was adequate. It was a little bit variable. We think that they need more training, which is doable, right? We can create training programs, but that it shows promise. So this is something that we weren't quite sure if we could even further abbreviate it, but we wanted to try, and this suggests that it's a worthwhile endeavor to do. So we're going to kind of keep moving in this direction to see how we could make further use of it. So like I said, this is one that's coming out in JSLHR, Journal of Speech, Language, and Hearing Sciences. So keep an eye out for that. It should be out truly any day now. This next study is in press with American Journal of Speech Language Pathology, or AJSLP, and this one was done in collaboration with Manaswita Dutta at Portland State University. It could not have been done without her immense efforts on this. But she has done and others have done some really lovely work in thinking about what are the barriers to folks using naturalistic language in clinical settings, right? Why don't people do this? And one piece of consistent feedback we've gotten is that they don't have a time-efficient tool, right? And APROCSA filled that need, right? It was a time-efficient tool. But the other big consistent piece of feedback that they've gotten out of that work is that clinicians don't have the training, either as part of their graduate programs or when they go out into their clinical practicums. They did not feel equipped actually to assess the language that matters the most to our patients, right? And so we thought, well, we can address one barrier very easily. How do we create a training that helps them feel more comfortable doing this kind of work? And so what we did was we created an expanded manual. You can see it here on the left-hand side of the screen, just the first page. It was, and this is all based on clinician feedback. I should back up a little bit. We wanted to co-design this, right? We didn't want to do it in a vacuum, even though us as a team were all also clinicians or had significant experience, clinical kind of encounters with folks with aphasia. So we worked with the clinicians actually, at the time, all of the staff clinicians working in adult neurogenics at Vanderbilt. And so they actually provided feedback on what they would like a training to look like, and we designed this training program around their feedback. So we made this extended manual and has all sorts of information about things they wanted to know. They wanted to know about what does discourse or naturalistic language assessment look like? How do you elicit it? What are the different types of ways we've measured it? What are the things we care about? They wanted to know a little bit about test psychometrics. A lot of us don't get training in that, and why should we care about certain things like reliability or validity? They wanted to know more about APROCSA itself, its background, its procedures, things like that, and they wanted definitions, more expanded definitions and examples of the features. And so we hit that with this training manual that we created. And then we also created a webinar. And so that's what you're seeing here on the center part of the screen. And so this is where we actually walk people through each of the features in depth. We give examples, we give scoring tips, and critically, we make use of the incredible resource that Aphasia Bank is. We have video clips of individuals who are all on Aphasia Bank that show you what those features are. And so this tutorial is about 90 minutes. It was pre-recorded. So we had everybody look at that. And then we actually brought everyone in and we had a gentleman, again, who had freely consented. I'm going to talk about that data set. I know I keep saying that in just a second, to freely share his data. And we got consensus scores for each of those APROCSA features. And we actually walked everybody through a guided scoring on him. And he was a unique individual who just happened to present with about everything. And so it was a really nice learning opportunity for all of us to get together and to practice that rating in real time. And so that was our system. It was about 3 hours in total, only required about an hour and a half in person. And then we wanted to think about, was it effective? Did actually people improve in terms of how reliable they were in using how reliable were they in using APROCSA? And so how we actually measured this was before training and after training, we had folks rate 6 samples of individuals with chronic aphasia. The first time around, we gave them no instruction. We gave them a brief manual, like, go for it. The second time was obviously after the training. What you're seeing here are the reliability coefficients, very similar to the ones I showed you for the previous study, for pre and post training. We had 8 clinicians in total. They're color coded there. You can see their initials, and then you can see that violin plot overlay that just gives you a sense of the spread. The dashed lines there are the qualitative interpretations of that reliability coefficient. So below the lowermost line is fair reliability, between the 2 dashed lines is good reliability, and above the upper dashed line is excellent reliability. And so what you can see here is that a lot of clinicians were in the good range and kind of had some modest improvement within the good range. A couple of them moved from the fair to the good range, and one of them had quite a bit of movement even within the excellent range. And when we look at this on average, we did get a statistically significant finding that the training did improve. Again, this is with a group of clinicians that were pretty experienced and worked in this setting where aphasia was a primary population that they saw. But what we also saw is when we tried to look at the amount of change and we were curious what might be associated with that, we found that newer clinicians seem to benefit the most, those with the fewer years of experience. And so the idea being that this training actually can kind of be a little boost or kind of a makeup session in what you might naturally acquire over many years, but wouldn't it be great if we're kind of training up the next generation to feel more comfortable to be coming in with that expertise and being able to, perform assessments and then maybe focus their interventions on more naturalistic language. So that was what we found. Since then, we have, as a team, been training folks across different institutions. So at this point, we've trained 180 students, clinicians, and researchers across 4 institutions. I am only one person, but I am always open to training folks and getting them, helping them be more prepared in the system. But there is a way you can walk yourself through it on your own, which I'll talk about in just a moment. But before I do that, I keep mentioning this freely accessible data set that I think is really wonderful to have. So I can't take credit for leading this work. This was led by, she was a master's student at the time and just started her PhD at University of San Diego and San Diego State University, Zoe Ezes. This was her master's thesis, and she was thinking about training. So this was actually the precursor. She wanted there to be a training program, but we thought to have a training program, we needed a data set that actually anybody could access, that people were comfortable sharing, and that had expert consensus scores so that you could actually compare your performance as a trainee to a group of experts who said, we thought that abandoned utterances was a 3 and that omission of bound morphemes was a 2, etc. And so she recruited 6 individuals in the chronic phase, and actually one of them is the gentleman we watched at the very beginning. She published this work back in 2022 in the journal Data, and inspired by that, right? So we use that actually in both of the studies I've talked to you about. But as part of the clinical training program and that paper, we expanded that data set because we felt the feedback that we were getting from the clinicians we worked with was that this is great. I'd really like to see more people. I'd really like to show more people to my other, the clinicians starting up on this, et cetera, et cetera. So we actually recruited 14 additional individuals, a couple of whom have longitudinal data associated with their samples. And they have freely accessible data, and we have expert consensus scores for them. And so this work was Could not have been done without the work of Manaswita Dutta, as I mentioned, but also Stephen Wilson and Mike DeRiesel and Kat Bryan, a PhD student at Vanderbilt. And so this data is available on Aphasia Bank, or actually very, very soon to be available on Aphasia Bank. The 6 people from Zoe's paper is already there. And I just am so thrilled to share that the training program is also there. So many, many thanks to the folks at Aphasia Bank for making this possible and doing the incredible work that they do. So the link is right there, or you can simply access it by going to the homepage, and it's listed under the training header. And so we have all of the materials. We've written kind of a description of how you can walk yourself through kind of a self-paced version of our training program. We do talk a little bit about the advantage of having someone guide you through parts of it. That's where I can come in, and you're always welcome to contact me, but just absolutely thrilled to have this out in the community. The last piece of the study that I'll share has to do with adoption, right? So it's great that we met this implementation barrier, that we found it to be effective, et cetera, but our clinicians, did the rubber meet the road? Did the clinicians actually end up using the tool? And so we actually talked to them a year after we did the training, and we're like, okay, what are you doing? Are you using it? And 75% of them had adopted it into their assessment. And those who hadn't actually either had kind of switched to a clinical practice where they were not really seeing folks with aphasia on their caseload, or they were in settings that they were doing research protocols where that just simply wasn't part of their protocol. So we got some really lovely feedback as to why they adopted it and how they had found it helpful. So I just wanted to close on the study with sharing that. So one clinician said, it really helps me think through how this person's aphasia is presenting and our specific areas for improvement. It gives me new terms and language. Evaluating speech samples through APROCSA lenses helps me capture a more complete picture of my client's speech language abilities. It has helped me describe behaviors associated with aphasia to families and other professions. The features and definitions on APROCSA allow the graduate clinicians, this is someone who moved to an academic field doing teaching and clinical supervision, graduate clinicians to listen for and document features that they would not otherwise recognize. And it is much easier to qualify and quantify expressive language deficits for milder aphasias. So really thrilled to get this feedback and to be hearing that APROCSA is there out in the wild. And so again, encourage you to make use of this tool if you think it would be valuable in your own setting. The last thing I'll leave you with, that I've really been thinking a lot about this work and where I'd like in terms of implementation to be taking it, is that, again, I said, this is what really matters to people and they care about their functional outcomes. And I talked a little bit about speech therapy. And so I would love to be using APROCSA in future to think about communicative success. So one way would be to take the out-of-box APROCSA and to actually be using it to be measuring, treatment outcomes, to be thinking about, how are people responding? We know that unfortunately, the findings are really quite modest or not consistent when we think about improvement in naturalistic language in response to treatment, but maybe there's a different way to measure it, and maybe there's a better way to measure it. And I'm actually not going to tell you that APROCSA in any way is the end-all be-all, because I think one of the problems is we're so deficit-focused, and APROCSA, yet again, is also primarily a deficit-focused tool. So how could we repurpose some of, its advantageous qualities, its time efficiency, its lack of transcription, et cetera, and to be thinking more about how are people successful in communication. So I'm going to leave you with this thought and with just a very brief clip of the gentleman we watched earlier being tested at a different time. And I just love this video because he's someone I think who really embodies communicative success. If I just measure him in a very deficits kind of lens, he comes out as having, pretty significant aphasia. But when I think about his use of prosody and facial expressions and gestures and thinking about writing or letters, he's such a phenomenal communicator. He figures out how to work around the challenges that we have and how can we better capture that. He's someone who's had a ton of therapy and says that therapy really made a massive difference for him. So how do we bottle that? How do we, that's another thing that's really hard to measure. But anyways, here, I had to end with it. Also, it's a video. He talks a little bit about cats, and in aphasia, we of course all love cats. So let me just show you this really quick.
And this is our last picture.
Woohoo!
So again, just kind of look all around.
Oh my
Yeah.
God, cats.
Mm-hmm.
Cats and saving. Oh, cats.
Right. All right. So with that and
And
with
this is our
that, I want to thank you all for your time and attention. This work has taken a village. And these are some photos of the incredible team members that have made it possible. Just so many thanks to the Language Neuroscience Lab at Vanderbilt University Medical Center, at University of Arizona, at University of Queensland. Stephen has been hopping all over the world and has been building just incredible programs along the way. And I just feel immensely privileged to have been a part of it and to met all these incredible people along the way. So many thanks to them and many thanks to you all for your time. And I'm happy to take questions.
Thank you so much for a really good talk, Marianne. I think you should be able to see our room here in
Hi.
now. Some time for maybe a couple of questions. We have some in the chat, but maybe if there's a question in the room. William?
Yeah, Marianne, thank you for the talk. Obviously, I really love the perceptual rating approach, and I think it has a lot of potential. I've got a lot of questions. I'm just trying to winnow it down to some pertinent questions. So with the lesion symptom mapping, you show that like 2 of the factors are more associated with, posterior temporal lobe kind of damage, and 2 of the factors are frontal. I guess my question is, how do you think that relates to our understanding of the psycholinguistics of language processing, right? Like typically, if we're thinking of like a sentence production model, you start with, grammatical construction and lexical selection, and then you sort of end with phonological encoding and motor speech programming. Whereas it seems like with your lesion factors, right, the grammatical construction and motor speech are sort of more aligned, and the phonological and lexical semantic stuff is. So how do you think about that, right? Do we need to reconceive of the psycholinguistic models in a certain way, or is there something else missing in the disconnect there, or what do you think?
I think it's kind of both. I think there's like different flavors of it. And so I think that sometimes I often think of something, that Stephen said he's often trained, he's trained more formally as a linguist, is that in some ways that can only take us so far. And a lot of times the brain is doing things that can kind of lead us to new and novel information that we might not have otherwise realized. So I do think in some sense we maybe should take a step back and be kind of thinking about, and I know that's something that we've done, and that are there other ways of conceptualizing things? I've been thinking a lot about even early work that talked a little bit, talks more about things in terms of selection versus access, like across domains, not even in terms of linguistic domains. I've been spending a lot of time thinking about compensation and how does compensation play a role in creating converging or diverging behaviors that could be related to speech or language, right? Why is it the fact that we get agrammatism and motor speech are so closely aligned, right? What is driving that? So on the one hand, yes, I think that for me, I think that this does suggest we should go back to the drawing board in the sense that we get a lot of converging evidence, but like also what are different terms or ways we could talk about things to maybe study them and identify new information. That being said, though, and I know we've had a little bit of a chance to talk about this, but I think it's really important to consider the cohort. And I think that the acute cohort had some really lovely advantages to it. And, hindsight's always 2020 in research, especially. But the disadvantage is that we are underrepresented in certain groups simply because they could not be tested. So either they simply couldn't engage in testing at all, right? Or they did testing, but they had no output. And so I think that before I, jump the gun and say, oh, we should rethink all of our models, I think that we should really be, and this is something we want to do, and I know I owe you an email, is to replicate things in a chronic cohort, right? And actually I've got some nice behavioral data. I've been fortunate to be working with Pittsburgh and Portland State on one of their larger studies too. I think that the chronic cohort just is going to look different. And I think that actually might align a little bit more with psycholinguistic models. But why is that? Why? And a lot of that work, in aphasia, at least aphasia-centric, is predicated on chronic. And why is it that we might see greater alignment that's somewhat cohort like dependent, and where people are in the curve? I don't have a good answer for that. I'd love to hear thoughts. I don't know if I really answered your question either, but I guess all of it to say, like, I think it could be both or neither.
Answerable. One minor question, I'm just gonna sneak it in if y'all don't mind. How much did you account for total lesion volume, and how does that relate to the non-language areas? Like, how much should we be thinking of that as critical functional contributions of specific regions that are sort of non-linguistic, and how we define that in the first place versus just lesion volume?
Fantastic question. And I think that's a really hard one to answer because we did play around with models and we controlled for it. But in that kind of a context, because of the collinearity between non-language damage and total lesion volume, we were getting some really wonky stuff. So we actually pulled it out. I think, that might actually take a two-step approach where you like built a model, you factored out lesion volume, and then you use those coefficients, that resultant data, and then you did it on the non-language ROIs. And unfortunately, we were just, again, over 200 patients, but not powered to do something like that. It's really hard to say. I will tell you that one thing that was really striking in the acute data was that we could have folks who had very large amounts of damage in the non-language areas and just like essentially a pinprick in language areas, and that fully aligned with like they had language deficits. They would resolve typically often by the time they hit 3 months or 12 months, but they had language deficits. So there is something about, at least acutely, that sensitivity of the language network to damage. But how does that work out over time when people have large lesions with lots of large, like non-language area damage and language area damage? That takes more work. And I've gotten some really lovely feedback on how to maybe express the non-language ROI or account for lesion volume. So all of that to say, I think we haven't fully accounted for it, and because of the collinearity issue, and I would like to look at it in more depth. And I think there's probably some similarity with this, some of the studies that find lesion volume to be an important predictor, right? There might be something there, but it's hard to tease it apart because there's damage in language areas there too.
All right. Thank you so much, Marianne. We are at the end of our time today. I know you have a question in the chat that I'll share with you if you cannot see it. So thank you so much. Thank you to our audience for watching both in person and online, and for the questions. And we look forward to seeing you in 2 weeks' time at the same time for another C-STAR talk. Thank you so much.
Wonderful. Thank you.